Welcome, everyone. I'm Jeff Folloder. I am a passionate patient advocate. I'm also a CLL patient and have been for the past 13 years. Currently, I'm relapsed, but I want you to know that I am living my best life right now, and I do events like these to help you live your best life. We're live with CLL Society's third Facebook Live event, Ask Me Anything, where we spend the entire event answering your questions with a CLL expert. And we are so lucky to have Dr. Brian Hill joining us today. There are no presentations, and we encourage you to ask your questions on the Facebook page, if this is how you're joining us, or through the Zoom platform. This event is dedicated to your questions, so ask them early to make sure we get to them all. Before we begin, though, I have a few important disclaimers to share. Nothing that is said today should be taken as medical advice. Any questions specific to your health and your treatment should be discussed with your healthcare provider. Also, the information that you post on Facebook will be shared in a public forum, so please do not post or share confidential information. And without further ado, Dr. Hill, would you please be so kind as to introduce yourself for our audience?
Yes, hi, Jeff. Thank you for the introduction, and I'm glad to hear that we have so many folks registered for the meeting. My name is Dr. Brian Hill. I'm the director of the Lymphoid Malignancies Program at the Cleveland Clinic, Taussig Cancer Institute. I have a major clinical focus in CLL, and I'm actively involved in research of outcomes of patients with CLL, as well as development of novel therapies to help patients with CLL and related conditions.
Thank you. That's great. As you can probably imagine, we already have a host of questions. So without further ado, we're going to dive right in. The first question that I have teed up is something that pretty much every new patient wants to know. Is there an average time from diagnosis to treatment? And if so, what is it?
Right. Yeah. So that's one of the common questions we get at the time of diagnosis of CLL. We, know that still in the modern era, the standard recommendation is watchful waiting or active surveillance without immediate treatment if you don't have symptoms or any other treatment indication that we can talk about. For most patients, the average time from diagnosis to treatment is on the order of years, probably on average about 7 years if you look at all comers, but of course not everyone is the same. So there are some factors that you can look at to determine the time from diagnosis to treatment. And those are some simple parameters, including the presence of lymph nodes, white count over 15,000, or an unmutated IGVH status, which if those are people in the audience aren't clear on what that is, we can talk about that. But those are some of the three things that give you points. And this is kind of like golf. You want to have a low score, not a high score. So the higher the score, the shorter time to needing treatment, and the lower the score, the longer. With some people, probably about 20% of patients, particularly those with 0 points, those are the folks that may go their entire life without needing treatment. But of course, it depends on your age of diagnosis.
So I just want to underline that there are a subset of patients that even though they're diagnosed with CLL, they're never going to need actual treatment.
That's right. Yeah. And it can happen, if you're diagnosed at the age of 50, that might be different, but the average age is 72. And so you may just sort of have this as a nuisance in your life for, the golden years as they were, and sort of move on at the end without ever having to do anything about it. But that's probably the minority of patients.
Interesting. Yeah. I have a more specific question about the 11q variety.
Yeah.
A patient is asking about being 11q and unmutated and wants to know sort of a basket of stuff going on with 11q unmutated. What are the first line treatments? What are second line treatments? is there a current life expectancy?
Yeah,
And I'll
sure.
turn that over to you.
Yeah, sure. So, for different molecular features, we can say that um, it can sort of correlate with treatment outcomes. In general, in the era where we used more traditional chemotherapy drugs, so the fludarabines, cyclophosphamide, and bendamustines of the world, those drugs are really most effective in patients with mutated IGVH status, which is generally favorable. So it's a little backwards. Mutated is in this case good. For patients like the one who asked the question with an unmutated IGVH, we would definitely, under no real compelling circumstances, would consider traditional chemotherapy. But we know that targeted therapies like the BTK inhibitors and BCL2 inhibitor, venetoclax with monoclonal antibody, that the outcomes, even with 11q deletion and unmutated IGVH status, the disease can be well controlled for a long period of time. Now, the question of survival probably comes up a lot, because if you look at older data, the survival, if you look at an old textbook from 5 years ago, it'll say that the survival of CLL patients is, so and so number of years. But what we can see over the years is it keeps going up, up, up. And that's good. That means people are living longer. The horizon, I don't think we're really even at the horizon yet. And there are some suggestion that in some circumstances that the survival of someone with CLL is really the same as an age-matched person without CLL. And so we're getting there. I think we won't really know with certainty for another 5 years, because you need to literally wait that long to see what happens. But I think that the survival overall, even with some of these higher risk features, is much, much better than what historically has been reported.
I have one more follow-up from this patient here. They're talking about counseling availability in dealing with emotions during treatment. This is something that I've noticed isn't talked about a lot. Would you care to comment?
Oh, yeah. I mean, for sure, the emotional toll of having a diagnosis like CLL is hard to understate, because it is a cancer. It is, potentially a threat to your health and livelihood. And there are some, occasionally sort of unpredictable things that can happen. Like hemolytic anemia can sort of occasionally come out of the blue and so forth. So there is a little unpredictable nature of the disease. It doesn't always follow a set trajectory, and that the fact that we're not treating it immediately upon the time of diagnosis sometimes causes folks, understandably, to be quite anxious. And I think you can't underestimate the emotional toll that can take. And then, of course, once people do need treatment, that is a whole other can of worms, so to speak, because now you're talking, well, I thought I was fine, didn't need to be treated. Now I need to be treated. Now, does that mean that, I'm going to run out of treatments? So any and all means of emotional support are always welcome.
Great. Let's switch gears just a little bit. Ibrutinib is actually somewhat commonly used treatment for CLL now. But we are an aging population, and sometimes we need to get things fixed, and surgery becomes part of our landscape.
Yeah.
What's the protocol for someone taking ibrutinib? Should they stop taking it? How does this work?
Yeah. So ibrutinib was the first of now 3 FDA approved what we call covalent BTK inhibitors. It's the most commonly used one because of historically it came first. And for people who are tolerating it, there's no necessarily any reason to switch. But we know that there are side effects and toxicities and some risks of ibrutinib, and actually all of the oral BTK inhibitors, including acalabrutinib and zanubrutinib. The specific question is regarding the risk of bleeding. which is a class effect of all these three drugs. Prior to elective surgery, so we generally classify procedures as minor or major surgery. So minor surgeries, things like colonoscopies, dental extractions, sort of simple things that don't require major incisions or general anesthesia. 3 days of holding the drug before the procedure is adequate. And if it's an uncomplicated procedure, then I usually tell people they can resume the next day, unless they have any sort of sutures or things, then I would hold at least for 3 days. For major surgeries, this would be any sort of cardiovascular surgery, thoracic surgery, abdominal surgery, neurosurgery. Those are ones where you usually recommend holding for 7 days before and 3 to 7 days afterwards, depending on the postoperative course.
Very interesting. Let's stick with ibrutinib for just a few moments. What do you recommend for ibrutinib patients who have relapsed? Is there another BTK inhibitor that will work well, or is it recommended to try a completely different approach?
Yeah, so for ibrutinib, the reasons for discontinuing or stopping therapy are about equally split between intolerance or side effects versus what we call resistance, or the drug stops working. The most commonly described reason for the drug to stop working are acquired mutations in BTK, which is the sort of landing site for the drug. The other drugs I mentioned, acalabrutinib and zanubrutinib, actually have the same binding site in the target of BTK. So typically we don't recommend switching if you're really if your CLL is not responding anymore to ibrutinib. There's not really a good rationale to continue with that class of drug. So your basically options are venetoclax, the BCL2 inhibitor, usually given with the monoclonal antibody, or there's now a new oral BTK inhibitor, which is slightly different from the 3 covalent BTK inhibitors I mentioned, and that's called pirtobrutinib. This is a new medication, which is a non-covalent BTK inhibitor, which has a different binding site or target sort of landing site in BTK. And it can work in people who've stopped responding to ibrutinib or the other covalent BTK inhibitors. I should add the caveat that it's currently FDA approved for mantle cell lymphoma, and it's anticipated to be FDA approved for CLL probably in the next 6 to 12 months. So if you really need it right now, there are ways of getting it off-label, it's called, but I would definitely talk with your oncologist about it if this is something that may be needed right now, because it is theoretically an option right now.
Staying on the ibrutinib train for just one more moment. This one's striking a little close to home because my next door neighbor is currently suffering with shingles, and it is not a pleasant experience.
No. Yeah.
And an ibrutinib patient asks, is there any special concern with getting the shingles vaccine? And will it help? Will it trigger an outbreak?
Yeah, great question. So it used to be that the old shingles vaccine, we said do not get, this is the old one, because it was a live inactivated virus. That vaccine is off the market. You couldn't get it if you wanted to anymore. So the new one is called Shingrix, is an inactive vaccine. There's no risk of getting shingles from Shingrix. It's 2 injections, several weeks apart. The side effects are like most vaccines. You can get some muscle aches and fatigue and tiredness. It is safe. The effectiveness of it, I think, is a little bit unclear. To be at best, there's sort of limited data. If you measure antibody levels or titers after people have had Shingrix, CLL patients tend to have suboptimal responses to this vaccine, particularly if they're on a treatment. So what I would say is if you're on treatment for CLL and you've had shingles, in the past, you probably need to be on acyclovir or valacyclovir as a preventative medication. If you've never had shingles, it's not necessary. It's not within guidelines or recommended to be on preventative medication for shingles, but it would be safe and reasonable to get the vaccine.
Interesting. So we have a patient who is MRD negative. They went through the fancy testing to determine their MRD status. I think this is a great question. Is their immune system working again? Are the B cells functioning?
Yeah. So one of the areas that the field is moving is away from indefinite treatment and more towards time-limited therapy if possible. With the oral covalent BTK inhibitors and the non-covalent BTK inhibitor, it's sort of unlikely that you're going to get very deep remissions to the point that you can stop therapy as on a time-limited basis. It can happen, but it's not common. With venetoclax-based treatment, and sometimes even with old-fashioned chemotherapy, you can get very deep remissions that can last for a long time. The deeper the remission, the better. And the way we measure that now is, there are, as you call them, fancy. There are some fancy tests that can determine whether you have as low as 1 in 10,000 cells or CLL cells. So there's different sort of assays. One uses flow cytometry, one uses DNA testing, but suffice it to say, if you're in a very deep remission with less than 1 in 10,000 CLL cells, it is safe to stay off treatment. You'll probably be in remission for a long time. And during that period of time, the further away you get from therapy, the immune system should reconstitute, but it's not entirely clear that it really gets back to quote unquote normal.
That makes sense.
Yeah.
I have another question that seems rather straightforward, but I suspect that the answer is much more nuanced than the patient is guessing. How long should I expect to remain in watch and wait?
Yeah, so in watch and wait, again, years on average. If you have some of the higher risk features like unmutated IgBH, high white count, and lymph nodes, probably going to be in the kind of 2 to 3, 4 years. If you have fewer of those points, it might be out to 5 to 6 years, or even as many as 10 years.
Gotcha. I've got another question here to bolt on to the treatment options. I'm under the impression that once treatment is started, that your immunity is even more compromised. Is this correct? Is it better for me to do riskier things like travel to Africa before I need treatment or after?
Yeah, so that's probably, as a general statement, is probably true that even if you haven't been treated for CLL, your immune system is probably not perfect right now. I say sometimes maybe it's an A- or a B+. And what that means is just having CLL kind of disrupts things a little bit. That being said, the best predictor of future sort of immunity to infections is probably what's been happening to you over the past year or two. So if you're never sick, never in the hospital, never have a sinus infection, you're probably, even if we measured your immune system, even if we found some abnormalities or low immunoglobulin levels, it doesn't necessarily mean you're really at that much of an increased risk. So yeah, if you want to travel internationally, that is depends on the country, because some of the countries do require, for instance, yellow fever is a live virus. So you probably want to look closely at CDC guidelines, talk with your oncologist, maybe see a travel medicine clinic to make sure that you've got the right vaccines for international travel. But yes, in general, once you start on the treatment wagon, the immune system, at least on treatment, is probably not going to get better. We know with monoclonal antibodies against CD20 that we do deplete normal healthy B cells and can result in some increased risk of infection during that exposure. And again, if you do time-limited treatment and you stop, then the period of time off treatment, the longer you go, the more likely you are to reconstitute or have a recovery of your immune system.
That makes sense. I'm going to ask a question that has come in that is near and dear to my heart. I have become somewhat of a healthy evangelist since my first treatment with CLL. I now do silly things like exercise and watch what I eat and manage all of my comorbidities. And
Yeah.
I think I'm doing a great job.
Yeah.
But the question is there anything that I can do to prolong watch and wait, to push that treatment horizon further down the road?
Great question that we get asked every day, and honestly don't have a great answer to. We all would love an herbal supplement, a vitamin, a special food that was clearly shown to help. You know, there's some studies that looked at green tea extract, you know, in high quantities, green tea extract seemed to lower the white blood cell count, but if you take too much, it can cause, you know, liver dysfunction. So there's no magic bullet on that, unfortunately. The things you're doing are all great things. And what I would say is the one kind of special sauce that's been shown over and over and over across all cancers that can make you live longer is physical activity. So physical activity, physical activity, physical activity. And even if you just walk, you know, every day a mile and then maybe push it a little bit more, walking is so valuable. If you can do more than that, cardiovascular, you know, get your heart rate up to 20 minutes a day with a high heart rate, at least a few times a week. These are all things that improve longevity of all people, but also cancer patients, and no reason to think that it wouldn't apply to CLL. So will it make your time to needing treatment shorter? There aren't any good data to show that, but it will certainly make your life better and your ability to tolerate any future treatment or complications better.
And interestingly, what I've noticed with the exercise is counterintuitively, it seems to be reducing my fatigue.
Yes, yeah, I'm actually glad you brought that up, Jeff, because probably the number one complaint I get from folks on watch and wait is fatigue. And fatigue is a really tricky one because there's so many things that can make people tired. But if we just look at a CBC and we say, well, your hemoglobin's normal, you have a normal red blood cell count, you're not anemic, you don't have, hypothyroidism, you don't have sleep apnea, you're just tired. And could it be the CLL? Sure. Would treatment make it better? Not clear. But again, I do sort of preach the gospel of physical activity, because what tends to happen if in the absence of physical activity is people become more sedentary, and they become, as a result, more fatigued. And breaking the cycle and going the other way leads to better sort of emotional well-being, improves cognitive functioning, improves energy level, ironically. So you're right. When people say they're tired and I say, go exercise, that's easy, easier said than done sometimes, but even walking and getting outside can be extremely helpful.
Excellent. I find the next question to be fascinating because so much has happened in just the 13 years that I've been dealing with CLL. When I first started, it was, the straight trio of FCR. You mentioned those components, and now we have so many options in the toolbox. The question is, how soon should I educate myself on available treatments while I'm in watch and wait? With the testing and the treatments and accelerating research, when would it make sense to start studying the current medications?
Yeah. So what I would say is, if you've been in watch and wait for some period of time and you're comfortable and stable, you don't need to, do nightly reading on the topic. You don't need to let it to consume your life unless you find it interesting and reassuring to do so. For people who are getting closer to needing treatment, then that's probably when you want to spend a little bit more time kind of researching what's out there. And when I say getting closer to needing treatment, if your white count continues to rise, if your hemoglobin is dropping, your platelet count is dropping, you're getting more lymph nodes, you're getting some night sweats, any of those things, then that's when you want to start to kind of scratch your head a little bit more and think about treatment. I will make a plug while we're have this great audience. I'll make a plug for the early intervention trial that I'm part of, which is being run through the National Cancer Institute's cooperative groups. So this is for people who've been diagnosed within the past 12 months. So if you've been on watch and wait for 3 years or 5 years, it's not going to apply to you. But for people who've been recently diagnosed in the past year, there is an early intervention trial for patients with high-risk features, which compares treatment immediately versus deferred treatment, which would be considered standard. And that trial is being run through the Southwest Oncology Group, or SWOG, and it is open at multiple academic cancer centers throughout the United States.
Excellent, excellent. Here is what I consider to be an awesome question. Can you explain the increased risk of secondary cancers in CLL patients, and what should we be looking out for?
Yeah, so secondary cancers sort of come into two main flavors. The one is skin cancer. So skin cancer most commonly is the nuisance kind of skin cancer called squamous cell carcinoma. These are the ones that, you know, many people, especially those in their 60s and 70s, you know, maybe with fair skin, who spend time in the sun or have during their lifetime, are at risk for just by, you know, virtue of their lifestyle. But the diagnosis of CLL, even in the absence of treatment, does increase the risk of that skin cancer significantly, probably doubles or triples it. So any kind of suspicious skin lesion in a sun-exposed area really needs to be seen and biopsied by a dermatologist. The question was, why do people get these? And the best explanation is probably, again, related to defective immune surveillance. So the T cells and all the healthy lymphocytes and other components of the immune system, they're there to keep you protected from infections, but turns out they also have an important role in surveillance of malignant or cancerous cells. And so people who have an early cancer cell, a lot of times the immune system identifies it and eliminates it before it becomes a true overt clinical cancer. So that is probably the explanation for the skin cancers. For the non-skin cancers, so other common, what we call solid tumors, such as breast cancer, lung cancer, colon cancer, people with CLL are not immune from those. The risk of getting those is modestly elevated, probably for the same reason. And other conditions are more commonly tied to the exposure to chemotherapy, like secondary leukemias and myelodysplastic syndrome. But given that we're moving away from the traditional chemotherapy drugs, those kind of secondary cancers are, I think we're going to see less of going forward.
Interesting. I know earlier you talked about the green tea supplements. Are there any other herbal supplements, any other things that we should be avoiding as CLL patients?
I don't know. So my sort of position on green tea extract is I don't recommend it. I don't necessarily tell people that they can or cannot do it. That's a personal decision. If you like green tea, that's probably the best way to consume green tea extract. As far as other herbals, supplements, vitamins, and so forth, you know, if you get a well-balanced diet with, you know, fresh fruits and vegetables and avoid processed foods and things rich in saturated fats like red meats and so forth, you're probably getting an adequate balance of, you know, antioxidants and other sort of naturally occurring substances. And it's not clear that supplementing with additional alternative medications is beneficial.
Got it. What are the tests that a new CLL patient should demand be done? What
Yeah,
knowledge are we gaining?
Yeah, so for patients who are most folks out there have probably been identified to have CLL through incidentally, what we call sort of by accident or on accident, based on going to the regular doctor and having a blood count drawn and having too many white blood cells. Or a common scenario would be preoperatively, you're going to have your knee replaced and you get a CBC and it, shows a high white blood cell count that persists. So flow cytometry is the test that's really used most commonly to diagnose CLL. There are other ways to arrive at the diagnosis, but that usually is already done at the time that you're referred to a hematology oncology doctor. And then once, you're sort of plugged in, the other tests that I think are useful is certainly the IGVH test, again, that puts you into the mutated or unmutated, because I think that is probably if you're going to only do one additional molecular test, that sort of gives you the best sense of the trajectory of, are things going to sort of tend to go slower or tend to go faster? And then again, mutated tends to go more slowly and unmutated tends to require treatment sooner. The FISH panel is a blood test that tests for molecular sort of chromosomal changes in the CLL cells. These aren't chromosomal changes that you can pass on to your kids. These are things just in the B cells that are gone bad. And it's helpful to know that from a prognostic perspective. It doesn't necessarily change what you're doing unless you're looking to be enrolled in the high-risk early intervention trial. So FISH, I think, is commonly used at the time of diagnosis. It's useful. If it hasn't been done and your blood counts are normal and stable and you feel fine, I don't know that you need to demand that it's done. Some people don't want to know that information. What I would say, however, is that it's much more important to get your FISH testing before treatment, because it can sort of influence the decision-making there.
That makes sense. And
Yeah.
I'm reminding you, this is Ask Me Anything. So
there you go. Yeah.
We have just a whole bunch of stuff. And
I don't see the question, so I'm letting you be the filter here.
Well, I'm going to ask a question that's here on my list, but it would be the question that I personally would want to ask you.
Okay.
Is there a cure for CLL in sight?
Yeah, common question. Great question. We probably can cure maybe 30 or 40% of patients who have mutated IGVH CLL by using FCR chemotherapy. We have data now going out 10, 15 years that show what we call a plateau on the curve, meaning that after 10 years or more, we have patients who've been off treatment for 10 years and don't have any evidence of CLL even at that long out. The problem with FCR chemotherapy is that it has a pretty non-trivial risk of causing other cancers, secondary leukemia, acute leukemia, myelodysplastic syndrome. And so if you got it 10 years ago and you're still in remission, that's great. I wouldn't, it's hard to recommend it in my practice because of that risk. Maybe upwards of 5 or 10% of people who had FCR will get one of those conditions, which are very difficult to treat and potentially life-threatening. So that's the known answer for curability, is that it probably is curable in with that treatment. Now, could we cure it with something smarter and less potentially toxic? If that's possible, it's probably going to require 2 or 3 really good drugs to do it. And venetoclax probably has to be one of those drugs because it gets rid of so many of the CLL cells. So there are studies of venetoclax with obinutuzumab, which is monoclonal antibody against CD20. There's also studies of venetoclax with the BTK inhibitors, and there's studies of all 3. And as you might imagine, the more drugs you use, the more side effects you might have. We don't really have concern that these drugs could cause secondary cancers because of the way they work, and they seem to be generally safe to add together, although there can be some low blood counts and some risks of infection. So I would say the jury is still out to say that we can cure CLL with these targeted therapies. We probably need another 5 years of follow-up to see what happens with, if we see again that plateau on that curve with some of these targeted therapies.
Fantastic. I know I have hope listening to that response.
And I will also, if we want, we can talk about CAR T cells, because I'm sure that will come up at a certain point from.
I'm pretty sure that there's several questions about CAR T.
Okay, so maybe we'll just touch on that. So
sure, let's do that.
We get a lot of questions about cellular immunotherapy. So the general idea with CAR T cells is you harvest the patient's own T cells and modify them to attack the cancer B cells. And this sounds like science fiction, but it works. It works particularly well in certain types of aggressive forms of B cell lymphoma, and a type of acute lymphoblastic leukemia called ALL, B cell ALL. In CLL, the studies now have gone back over 10 years that have shown some patients, in fact, some of the very first patients treated with CAR T cells still have no evidence of CLL in their body after 10 years. The problem is that that outcome doesn't apply to most patients who've received CAR T cells through the clinical trials that have been done. The response rates are generally pretty good, but they're not as good as the drugs we have, and they're much more complicated to give. And there can be some serious complications. You have to be in the hospital to receive the treatment. So I do have patients say, well, why are we messing around with these drugs? Let's go straight to CAR T cells. I don't think we're there yet. We're doing a lot of clinical trials of CAR T cells at our site and other sites. And it's usually reserved for people who've had a BTK inhibitor and venetoclax. But all that being said, it may be a pathway to cure. It's just right now it seems that it's not promising enough to recommend across the board.
That makes sense.
Yeah.
I have an interesting question having nothing to do with CAR T.
Okay.
We have an RN who was surprised. Now, actually, in parentheses, it says shocked with an exclamation point, to find that she no longer has a measles titer.
Okay.
Is it ever allowed to have live vaccines? That no longer works at a school without 100% vaccination.
Right. Yeah. So for measles, that is part of the MMR vaccine. And I have to confess, I would have to look that one up because it doesn't come up often. I would double check on that before I make a comment. I don't want to give any misguidance.
Not a problem. Here's a different question. Where's the best place in the US to go for a second opinion on CLL? Where are most of the research and clinical trials now being conducted? So I know that's sandbagging a little bit, but I figured it would be a good setup for you.
Yeah, well, what I would say is that there are generally for sort of being on the leading edge of research and development of a field like CLL, it's typically done at the academic medical centers. We all sort of work together. So there's places that we collaborate in a lot of scenarios. We share data, we publish together, we do clinical trials together. And, sometimes when we have challenging cases, we ask each other, what would you do in this circumstance? So what I would say is there's not, it's like saying, what's the best kind of car? Is it, a Porsche or a Lamborghini or a Ferrari or a whatever, Mercedes? So there's a lot of good things at all these places, and it's not clear that one of them is better than the other. what I would look at is just basically the hematologist oncologist you're seeing. Is their practice really, highly focused or exclusively on CLL? Do they do a lot of clinical research in CLL and publish in that space and have a lot of clinical trials? Because those are the kind of things that give the most experience and sort of provide most informed decision making.
Very nice. Very good. I will give you an aside. The answer to the car side of it is Ferrari.
Oh, there you go. All right.
Yes.
We know what Jeff drives. All right.
Yeah, not yet, but I'm working.
Yeah. Okay. Okay.
We have a patient who says, I'm on a BTK inhibitor and they're getting pain flares in the areas of their lymph nodes. Is there anything that can be done to alleviate the pain?
Yeah. I would be curious to know how long you've been on the BTK inhibitor, because if it's a new prescription or a new medication, then I would probably stick with it. If you've been on it for some time and your lymph nodes are causing discomfort, I would be a little concerned that they might be enlarging and a sign of what we call progression or worsening of the disease. So maybe getting some imaging. We try not to do tons of CAT scans, CT scans, if we can avoid them, but this might be a scenario where getting CT scans now and in the future might be helpful to get objective a sense of what's happening. And if there's one particular area that's getting bigger, you sometimes might need a biopsy to make sure we're not missing something like a transformation. But if it's really just the side effect of the medication and you think the medication is working, you can, depending on the medication, most of them can be dose reduced or dose decreased in frequency to see if it's a side effect of the drug.
Again, in terms of non-high risk patients, do you recommend that they stop treatments for prolonged periods?
It would depend on the treatment. So with the BTK inhibitors, again, if you've been on it for some period of time and have to stop it for whatever reason, maybe it's the cost, maybe it's a side effect. If you're in remission, meaning normal blood counts, normal physical exam, and no symptoms of, B symptoms like fevers, chills, or night sweats, it's safe to stop taking a BTK inhibitor like ibrutinib or acalabrutinib or zanubrutinib for a period of time. Sometimes, if it's early on, people will have flare of their B symptoms when they stop the drug for a period of time. But I have had patients who had to stop it, for instance, a major surgery, and they stayed off it afterwards and just sort of stayed off it. And on average, we know from some of the original trials that on average, you can stay off it for sometimes up to 2 years. So it's reasonable to, but I don't, as a routine course, recommend stopping BTK inhibitor.
Interesting. Here's a question that has come in. The patient is 53 years old and starting obinutuzumab and venetoclax next month. In the physician's CLL group, there were different opinions on just how burdensome the treatment is going to be. What has been your experience? Should this patient plan on stopping working for the first couple of months or just ride with it?
Yeah, so obinutuzumab is a very effective monoclonal antibody. When it's combined with venetoclax, it's typically given as what we call a test dose on the first day, and then ideally the full dose on the second day. And then there's a couple more weekly doses. And then after that, you sort of lead right into the 5-week venetoclax ramp up. So those first approximately 8 weeks in a row, you're sort of at the cancer center every week, you're coming back and forth. There can definitely be what we call infusion reactions to that first dose of obinutuzumab. Those can be characterized by, shaking, chills, and sort of lightheadedness or back pain, and just sort of feeling tired that night. So I do try to recommend people take the day off, certainly those 2 days and maybe a couple of days afterwards to make sure that they get up and running on the obinutuzumab safely and without major problems. But after, after those first 3 or 4 weeks, you should be, pretty much feeling pretty well. And the venetoclax is pretty well tolerated once you start taking it the low dose and ramping up. So probably would take at least 3 or 4 weeks where you have a lighter duties and have the sort of flexibility of taking time away from work if possible.
Let's turn to a topic that I am certain is on everyone's mind. It's not over. I don't think it's going away, but COVID is a thing, and it's absolutely important for CLL patients to understand this.
Yeah.
The question goes like this. I'm 60 years old, diagnosed 2 years ago, currently in watch and wait, so no treatment, treatment naive. They've lived in a bubble since COVID started, trying to avoid COVID because they're very worried about infection.
Yeah.
Do you have any advice regarding COVID now that we don't have Evusheld anymore?
Yeah.
And how well are the vaccines working for us?
Right. Great questions. We get a lot of questions about this, as you can imagine. What we can say about COVID, as we all know, it's probably not going away. And living sort of in a complete bubble in your basement from now on is not a really attractive way of living. We definitely saw, in the early waves before we had widespread vaccination, a lot of really sad cases of really sick people with CLL and not. Since we've had the vaccines and now we have much better therapeutics to treat active COVID infection, including Paxlovid and the monoclonal antibodies and so forth, it's uncommon to see really severe cases in people who haven't been previously treated. That being said, for people who've been treated, we do see sometimes, people being hospitalized because of difficulty breathing and so forth, but certainly not anywhere near the severity of infection and problem that we did early on. So what I would say is, if you're on active surveillance and you haven't had recurring severe infections before COVID or of other types, and you've been vaccinated and you're otherwise in reasonable health, I think it's reasonable to sort of get out into the world. Now, the logistics of that are obviously complex because the universal masking doesn't occur anymore, even in airports. The only place where there's universal masking basically is hospitals now. So if you go out into a public space, whether it's church or a shopping mall or an airport, and you're wearing a mask, I think you're probably pretty well protected. And that's probably the kind of best advice I can give. But a lot of it does depend on your, of course, age, your other medical problems if you have any, and just in general, risk tolerance is an individual decision, and it's hard to give recommendations for what your risk tolerance could be, because there's downsides to being completely isolated. The social isolation is I think a real problem.
So do you have any experience with a product coming out from Israel called Innovid? I believe it's pronounced.
Yeah, I've heard of this product a few times. I haven't recommended. I've had a few patients use this product. It's essentially a nasal spray that provides some barrier protection to the mucosal lining of the nasal passages. It theoretically could provide some protection, not just against COVID, but against any and all respiratory infections. I believe it is going through some more rigorous clinical testing, phase 3 trial and so forth. But as of now, my experience is limited to anecdote.
Got it. I see this question come up all the time on one of the Facebook CLL support groups. The subject is insect bites. And for some reason, CLL patients, not all of them, but a lot of them seem to react horribly to insect bites. Can you tell us what's going on and if there's a good way to treat them?
Yeah, so it's pretty well described phenomenon that again, not everyone, but if you have lymph nodes from CLL, mosquito bites or other insect bites can lead to this really kind of over exuberant inflammatory response, sometimes big painful lymph nodes. Again, it's probably related to what we use the word dysregulation, which basically just means that the immune system isn't in perfect balance. So some of the inhibitory cells that are supposed to squelch down the immune system are probably present in lower amounts. And so you get sort of this overreaction to the insult of the insect bite. Not a lot to be done about it. If they usually resolve with time. If it's really painful, certainly a short course of prednisone or other steroid would be effective. We're talking about systemic prednisone or steroids. So like a 5-day Medrol pack or something would probably help. But usually by the time we have people calling about it, they usually say it's getting better. So usually it only lasts for a few days.
Got it. Here's a great question. The patient wants to hear your views, continuous treatment or fixed duration. Which is your preference?
Yeah. So we get that question a lot because if someone's on their frontline therapy, you can choose just to go on a BTK inhibitor, basically as a new medication. We say for life or forever. It doesn't necessarily mean it'll be forever, but certainly with no plans to stop, as long as it's not causing undue cost or undue side effects. The other option is the approach of the time-limited therapy, most commonly as what we call standard approach, would be the combination of obinutuzumab with venetoclax. It is more involved in the sense that, as we talked about, that requires like these weekly visits for about 8 weeks. And then after that, there's one infusion a month for another 5 months while you take the daily oral venetoclax for 12 months. It is more difficult to do, but if someone really asks, if they're willing to do either, I tend to steer that way because I like the idea of a time-limited duration of treatment with treatment-free intervals, again, during which time maybe the immune system recovers, and maybe, we don't have long enough follow-up, but maybe you are done for 10 years. There's probably the longest follow-up we have from the original trials show that after about, 5 or 6 years, more than half the patients still don't need treatment. Somewhere about 70% in that time frame don't need treatment again. So that doesn't necessarily mean they're cured, but they're off treatment and not having side effects. And again, immune system should be recovering. So that's, I think, the way the field is going. There's a lot of interest in, rather than using obinutuzumab, using the BTK inhibitors with venetoclax for a year. And those studies have been done, and it is a very effective treatment. It's not ready for prime time in terms of what we call on-label or on guidelines to do the two together as the frontline treatment. But time limited has certain advantages.
Great. The next question sounds like I should have asked it because it sounds just like me. The patient says, I often hear you'll die from something else besides your CLL. But the average age of a person diagnosed with CLL is around 70. I was diagnosed at 48 years old. Can I reasonably still expect to live a normal lifespan and die from something completely unrelated to my CLL?
And how did this person tell us their age? I'm sorry.
They're 48 years old, and
48.
the reason why I'm relating so well to this,
right?
I was diagnosed at 46.
Yeah.
So this means something to me.
Yeah, no, for sure. What I think we can say is that, especially over the past decade, the pace of discovery of CLL treatments has outpaced the disease. In other words, we got many patients who, needed treatment some time ago. They got some treatment and then they needed another treatment and they received something that like the BTK inhibitors and then the venetoclax and so forth. So with the rapid advance in cellular therapies, and the significant amount of research and development going into CAR T cells, I don't think it's out of the realm of possibility to say that we'll be curing more people with CLL in the next, 5 to 10 years. That being said, it's hard to prognosticate with all of the factors that can happen. But my general sense is that, again, that the survival of people with CLL is probably going to get closer and closer to the general population. Now, could there be complications of treatment along the way? And, obviously infection is sometimes, as we found out with COVID, can be a bigger risk than the actual cancer. But because our treatments are less immunosuppressive than they used to be, hopefully people are going to have fewer problems with infections as they get into their later years of life.
Dr. Hill, this has been fantastic. As you can imagine, we've got many dozens of questions that we're not going to have enough time to get to. So I hope you come back and join us again.
Of course, yeah. I enjoyed, always enjoy these sessions, and I'm always really impressed by the quality of the questions, and you did a wonderful job moderating. I'm sure you're probably feeling like you wish we had 5 more hours to read every single question. I would encourage people who are near a referral center, if they're not getting all their questions answered on a forum like this, to make a trip or a virtual trip to one of the treatment centers. And there was a question about good places to go, and I'll give a plug to the CLL Society, which does curate a list of providers at centers. Now, some of the more populous states and parts of the country have more providers who specialize or focus in CLL. Of course, some of the less populated areas have fewer people, but it might be worth a trip, or depending on the state, sometimes you can even just do virtual consult.
Is there anything else you'd like to share with our audience? We've got a bunch of people on Zoom and a bunch of people on Facebook. So this is your grand opportunity.
Yeah, I would just make a plug for continuing education, continuing the outreach of the CLL Society patient support groups. I think that this kind of knowledge is power approach is really powerful. And I would also just keep it on your radar for new patients to consider the early intervention trial as an option if you have high-risk features. And I'm sure that study is on the CLL Society website, but it's something that's available across the country.
Thank you so very much for sharing.
Very good. Thanks for having me.
I'd also like to thank everyone who joined us today online. A few brief reminders. Please complete the short event survey linked in the comment section on Facebook. It will also be shared with everyone who registered. This is our third Ask Me Anything Facebook Live event, and we really want to hear your feedback. Please join us on April 12th for CLL Society's next webinar focusing on the early journey of CLL. If your question was not answered today, please send it to our Ask the Expert email service. The webpage for this free service will be provided in the comment section on the Facebook page and can also be found on the website under programs and support. Please remember, CLL Society is invested in your long life, and you can invest in the long life of CLL Society by supporting our work. Thank you from CLL Society and from me personally. I hope everyone enjoyed this seminar.